Hello everyone, my name is Alon Armstrong and I'm a new veterinarian thanks to St. George's University School of Veterinary Medicine, and I'm also currently a Master's of Public Health candidate. And this presentation is part of my MPH practicum, where I will be discussing COVID-19 and the pandemic that has been brought upon us, as well as the disaster it has caused. And the goal here is to look at all of this primarily through the lens of public health. So I have a list of learning objectives here, and basically these are the takeaways that I'd love for you all to have. Some of you watching may already know the answers to these questions, but for those of you who don't, listen closely throughout the presentation, and hopefully I will be able to provide you with a better understanding of what's going on. First and foremost, I think it's important that we start off with the anatomy of a coronavirus. Now, obviously, this presentation is not grounded in virology. However, it's still a good idea to kind of have an understanding, however vague it might be, of what exactly we're dealing with. We see these images thrown everywhere online and in the news, so just to kind of get a better understanding of what is possibly infecting us or what is infecting our neighbors, etc., I think would be a great way to start. So coronaviruses in general, they are part of the Coronaviridae family, and they're broken down into about 4 different genera, which include alpha coronaviruses, beta coronaviruses, gamma coronaviruses, and delta coronaviruses. And all these different coronaviruses are responsible for different disease processes in different animals, whether it's cows, cats, dogs, pigs, and obviously humans. Different coronaviruses affect different species. And for the sake of this presentation, the coronaviruses that I'll be talking about today, including COVID-19, they are a part of the beta coronavirus family, or genre, excuse me. And it's also important to know that as far as the ones that we typically are infected with, we have what I like to call the simple coronavirus infections, which are responsible for, our colds, like the upper respiratory infection, and sometimes GI upset. So we have gastrointestinal infections that are sometimes responsible or sometimes brought on by coronavirus. And then, of course, we have our more deadly ones, which I'll get into in a bit. So overall, they are positive stranded RNA virus. And as you can see here, they have different protein structures to them. And this one, S, that's the spike protein, which is a glycoprotein, and this one is typically responsible for mediating attachment to the host's receptor, which in turn makes it perfect for vaccine development. And then we have our M protein, and that is, generally speaking, the most abundant protein structure on this virus, and it's responsible for the shape. Now, this is just a very vague presentation of what these proteins are for. And then we have our E protein here, which is responsible for, the ion channels and viral replication. Again, this is very, very generic, what I'm telling you here. Virology is so complex, and again, I'm not going to get into all the details. And, excuse me, inside our virus, we have the N, which stands for the nucleocapsid, and of course it contains the RNA strand, which you can see here. So I hope you guys have a better understanding of what you're seeing in images. Just to kind of go through history, we always should learn from history. I'm going to talk about briefly past viral epidemics that we have experienced. So first and foremost, we have SARS, which occurred in 2002, that SARS outbreak, primarily in China. And this was such a disaster as far as infectious disease outbreaks go. And then we have our H1N1 influenza outbreak, which occurred in 2009. It was purported that this outbreak began in Mexico City and subsequently spread. And then we have MERS coronavirus, which originated in Saudi Arabia, discovered in 2012, and subsequently spread throughout various regions as well. For the sake of this presentation, I'm going to focus on, as far as history is concerned, SARS and MERS, because they are both coronaviruses. All right, let's talk about SARS. As I said before, it originated in 2002, and at the time it was thought of as the worst human disease caused by a coronavirus. Now, it was found to be zoonotic, though there's still some questions to that as far as transmission goes. Originally, it was thought of that the disease was found in bats, and then civets came into contact with bats, bat droppings, etc., and then humans came into contact with civets. And of course, this would have been at a live market or those wet markets that are found in that area, southern China. Then in November 2002, the first case of atypical pneumonia was discovered in southern China. Since then, from December 2002 to July 2003, around 30 countries experienced cases of SARS, resulting in 8,000 confirmed cases and 800 deaths. This leaves a mortality rate of about 9 to 10%, which one might say, oh, that's quite low. But not really. I mean, that's still scary to know that you have this novel disease outbreak resulting in 9% mortality rate. The other thing to consider is transmission. As I said before, originally it was thought that it was primarily zoonotic, and just to clarify, zoonosis or zoonotic means a disease that's transferred or transmitted from animals to humans. But as time went on, there was some debate as to whether this was also human-to-human transmission. So, direct transmission primarily through respiratory secretions and feces. Symptoms included fever and influenza or flu-like signs, and those were frequently reported. Of course, more frightening symptoms such as coughing and pneumonia, etc. But as far as the frequent, nebulous, sort of non-specific clinical signs, these were the ones that were frequently reported. Currently, a vaccine is in the process of being developed in China. They are in the process of working on an inactivated SARS coronavirus vaccine. So some public health considerations here. The biggest factor for this SARS outbreak at the time was the fear that it could recur. Obviously, it was such a nasty, frightening outbreak to begin with, and even though they managed, the Chinese government managed a mass mobilization to kind of get things under control, what if it happens again? What if this virus is used, is weaponized and becomes a tool for biological warfare? You also have to think about globalization, which means people traveling, people moving about, immigrants, trades, etc. The world is no longer at a standstill. Everyone is moving. Airplanes are going throughout the day. Ships are taking off on sea. No one is staying put. So globalization increases the chances of disease spread. Of course, another important thing to think of is wet markets. That is a part of some areas in Chinese culture. And considering that it has been surmised that this outbreak originated as a result of wet markets, how do you prevent that from happening again? Then you have to think about the socioeconomic impact that this disease would have in a country, on the government, the strain, the burden. And I have healthcare burden as my next point, but when we're talking about trying to keep this disease contained, we have to think about quarantine and the impact that this is going to have on the economy because people are no longer spending. People who are sick, they can no longer work and provide for their family. This outbreak cost the government, the Chinese government at the time, at least $40 billion due to decreases in economic activity. So again, when you're talking about countries not wanting to trade with China or China not even being able to trade for obvious reasons, it has an impact on various parts of the society, of the country. Then, of course, healthcare burden. That one goes without saying. People who are sick, they fill up the hospital beds. If your healthcare system cannot support the number of people getting sick, whether or not they end up succumbing to the illness. They still wind up sick before they succumb, and they end up in hospital beds. And depending on how pathogenic or how virulent or how deadly or how likely this virus is to cause disease, you can easily overwhelm your healthcare system. How many doctors do you have to support the number of people who are ill, the number of people who need help? And of course, depending on where the disease is in a particular community, etc., some areas might have more healthcare support than others. And lastly, an interesting thing that I came across during my research was this People's Republic of China law on the prevention and treatment of infectious diseases. This was initiated in 1989 and later amended after the SARS outbreak. So what's an outbreak without a little political drama? During that time of the outbreak, a lot of people felt as though the Chinese government, they were not being very forthcoming with reporting. They were not being very forthcoming with keeping everyone abreast of what was happening. They were even accused at times of underreporting. According to a 2004 article titled "The SARS Epidemic and Its Aftermath in China, A Political Perspective," the author clearly illustrates the loopholes found in the aforementioned law. One of them involves the fact that atypical pneumonia at the time was not listed in the law as an infectious disease that must be under surveillance, which allowed local government officials to not report it to the necessary entities. Moving on to MERS. As I said earlier in the presentation, MERS was originally discovered in Saudi Arabia, so it initially began in the Middle East and gradually spread out, as you can see here in this map. It does have a zoonotic component to it, just like SARS, in that there are a lot of genetic similarities found in bats as what was found in humans, as far as the strain of coronavirus is concerned. Camels play a huge role in this transmission process, as again, very strong genetic similarities were found in camels that had this disease as well, and humans. And there's still a lot of research going on, but it's right now more likely that the focus is going to be placed on camels more so than bats. With camels, generally speaking, they do become infected, but it's kind of like a mild manifestation of respiratory disease compared to what humans face. And as you can see here in this map, in certain areas in yellow, there is a camel-to-camel transmission of the disease. And then in red, where primarily this is where Saudi Arabia is, we have camel to human, and then from human to human transmission. So kind of similar to what we were seeing with SARS, where it started with, civets to humans, and then human to human. And then in other areas, more so in Europe, it's more human to human. So 2012, as I said, is when this virus was first discovered. And between then and 2018, around 27 countries ended up seeing this disease, with 2,200 reported cases and 800 deaths. The mortality rate is actually much higher with MERS than it was with SARS, about 36% mortality rate. So if you were frightened with a 9 to 10% mortality rate with SARS, imagine MERS at 40%, roughly 40%. Transmission, again, somewhat direct, and camels play a role. So they were finding that people who worked a lot with camels, as is the culture in that region of the world, they tend to have more cases. So the incidence was higher. There were more cases of MERS in that population of people, and their symptoms were actually a little more severe than those who were not in direct contact with camels. This MERS coronavirus was also found to be in the environment, and of course respiratory secretions. So symptoms range from asymptomatic to fever, like SARS, to pneumonia, to even death. So as you can see, kind of nebulous, kind of nonspecific. As far as vaccine is concerned, they were having some difficulty infecting mouse cell lines with this virus due to the receptor that the S spike protein that I showed you earlier. That S spike protein binds to a dipeptidyl peptidase 4 receptor, DPP4. And as a side note, the S protein from the SARS coronavirus and COVID-19 does not bind to DPP4 as the MERS coronavirus does. Those two viruses, COVID-19 and SARS coronavirus, they both bind to the angiotensin converting enzyme 2 receptor, also known as ACE2. And there are differences with the mouse DPP4, making it a little bit difficult for them to move forward with vaccine development. However, progress is currently being made. So, public health considerations for MERS coronavirus. The severity of the disease. Of course, 40% mortality rate is frightening. So when we think about this, and when we think about globalization, you have to be really, really concerned with the ability of this virus to really take a strong hold, causing immobilization, thereby debilitating the public health infrastructure. So disease surveillance is essentially where you are checking from time to time by running tests, screening to see what are our numbers like now. How much of a stronghold does this virus have in this community, in a particular community, in this country, etc. Depending on which country is affected, depending on, and I'm just being crass here, how much that country or community can actually afford to participate in these surveillance-like programs, it might be difficult to actually get an accurate representation of what, real-time data looks like. Just like with SARS coronavirus, where we were talking about wet markets and culture, well, with MERS coronavirus, we're talking about camels and culture. So Saudi Arabia and different parts of Africa and other parts of the Middle East heavily use camels for modes of transportation or what have you. And it's difficult whenever you have such a strong cultural component, whenever you're trying to figure out how can we make adjustments to decrease, modes of transmission of this disease, etc. How do you completely eliminate camels from a culture, from a country? You can't really do that. Number one, ethically, that would be quite challenging. And of course, culturally speaking, to tell a people who have had things like wet markets and camels as a way of life for many, many years, to tell them that they're going to have to discontinue the use of that, that won't go over really well. And of course, socioeconomic impact that a disease with this severity will have on a community is something to consider as well. And just like SARS coronavirus, we have to take into account the healthcare burden. Now we're going to fast forward to November 2019. I remember where I was when I first heard about China's first confirmed case of pneumonia of unknown origin. It was surely a case that we all hoped wouldn't turn into anything. Unfortunately, it did. That one confirmed case in China, at the time they didn't even know it was COVID-19, turned into something much greater. It was found to be a case of pneumonia of unknown origin. And that one case turned into a cluster of cases. And of course, this was out of Wuhan. And then they're trying to figure out what is going on. So they try to rule out conditions such as influenza, avian influenza, adenovirus, even SARS and MERS. They started to consider, could this be SARS? Could this be MERS? Are we seeing a resurgence of these diseases? This just goes to show you how frightening, how virulent, how nasty this disease manifestation was. Fast forward to early January, when the CDC gets involved and they issue a travel notice for Wuhan, China, due to the pneumonia clusters that they've been seeing. As I've mentioned before, SARS and MERS were considered as a possibility to explain the enigma that was happening in China. And the fact that the CDC did not consider more stringent reactions to what was going on raises an eyebrow. Fast forward to later on in January, when even though China was quick to kind of, again, enact some sort of mass mobilization to kind of, contain what was happening, this novel coronavirus was not considered a public health emergency and was not considered to be an international concern. Until finally, the WHO on January 30th finally declared this outbreak a public health emergency of international concern after 18 countries reported cases, and 4 of those 18 reporting human-to-human transmission. So as time was going on, the rest of the spring, we're finishing out January, we're going into February. We're all kind of looking like Kanye West here with the news that we're hearing, these articles that we're seeing, the way things are kind of unfolding. Now it's not just in China, it's in Taiwan, it's in Vietnam, it's in France, it's in Italy, it's in the US. And we start to get really concerned. By March 11th, the WHO declared COVID-19 to be not just an outbreak, but a pandemic. Again, here we are, all of us, getting news from every single source possible. We're talking to everyone, trying to understand what is really happening. We're getting different reports on the news. Wear masks, don't wear masks. One media outlet is telling us this, another media outlet is telling us that. We don't even know who's and what is credible anymore. There is clash in leadership with Dr. Fauci and President Trump. Again, who do we believe? What do we believe? What are we supposed to do? So let's now talk about SARS-CoV or coronavirus 2. I do want to point out that it was called SARS-CoV-2 because of the similarity that it has with the SARS coronavirus. However, due to keeping everything simple, it has since been named COVID-19, which is just an acronym for Coronavirus Disease 2019. To date, it is now the worst human disease caused by a coronavirus. Initially, we were considering a zoonotic component in that bats possibly transferred this virus to pangolins, and from pangolins to humans, all in a wet market setting similar to what we saw in SARS back in 2002. Now, it's not just animal to human. We're obviously seeing human-to-human transmission as a primary mode of transmission of this disease. The first case of pneumonia, again, was in Wuhan, China, reported in 2019. That doesn't necessarily mean that this wasn't happening before. It's just what was actually reported was dated back to 2019, November. So from then until now, this disease has been declared a pandemic, meaning it is seen everywhere. Every single country, every continent except for Antarctica, as far as I'm concerned. And our numbers, we are now at 9.1 million cases with 475,000 deaths. A mortality rate for this disease at this time is about 5%. But don't be fooled. This does not mean that it's not something that we should ignore. Our morbidity rate is about 50-something%. And when I'm going to get into the details of this disease in a bit, but when we think about the secondary complications of this disease, so in other words, even though only 5%, generally speaking, are passing away or succumbing to this disease, those who are recovering could very well have some lifelong complications. And just to kind of backtrack to the mortality rate, so for the general population, it's 5%. However, when we kind of, think about this in clusters and stratify our data based on groups, So we have age group, we have ethnicity, etc. The numbers are more variable. Transmission. So protracted coughing and sneezing in closed spaces makes for aerosolized transmission. And just with the coronaviruses that we spoke about earlier, respiratory secretions and feces. Now, it's been reported that there are other modes of transmission as far as sexual transmission, etc. But the more common way of getting this disease is being in closed spaces with an infected person and respiratory secretions and feces. Now, I actually have to mention the fact that there have been quite a few studies demonstrating the virus particles on surfaces, which would make for indirect transmission as you touch a surface that is covered in enough virion particles to cause infection once you put your contaminated hand on your face, in your eyes, in your nose, in your mouth. Incubation period for this disease ranges anywhere from 3 to 12 days, and that is with a 95% confidence interval ranging anywhere from 9.2 to 18. This is important when we think about the quarantine time that we've been hearing of 2 weeks. Anywhere in that time period, one would expect to develop symptoms if we are indeed infected. RO simply means the reproductivity rate of this disease. So it has been calculated to be 2.2 compared to SARS, sorry for the typo, where there was an R naught of 3. So this simply means that if I'm infected, I will pretty much infect 2 people. And those 2 people who are infected, they will each go on to infect 2 more people. And that's how replication happens. That's how the numbers of infected people creep up, and that's how we see proliferation of this disease. So diving deeper into this virus, again, we have been hearing a lot as far as what this virus is capable of, what we're seeing, what we're not seeing, etc. So I'm just going to break it down a little bit. I'm not going to get into too many details, but just enough so that you can have a bit more understanding. So symptoms can range anywhere from mild to severe to critical. Mild simply means that you will sometimes have a case where you have no pneumonia, or you have a sore throat, a little bit of coughing, dry coughing, maybe mild pneumonia. Apparently, based on research, the majority of our cases fall in this category. Creeping upwards to severe, we have issues with breathing, so that's called dyspnea. Then we have increased respiratory rate, so anywhere from 30 breaths per minute and above, increased respiratory effort. We have very low blood oxygen saturation. We have infiltrates in our lungs. Usually in this stage, people will be placed on a vent, but even that is being debated lately as far as whether it's helpful or hurtful. Critically, you will see respiratory failure. You will see septic shock. You will have multiple organ dysfunction, etc. Usually when you're in the critical stage, it's very difficult to come back. Then we have what's called complex pneumonia, meaning they don't really yet understand how this pneumonia manifests, because it's unlike anything they've ever seen. Looking at CT scans, the distribution of the lesions in the lungs is unlike anything they've ever seen. Then we have the cytokine storm. I'm pretty sure many of you have been hearing this term lately. So basically what happens is, usually when we are infected with something, our body releases signals to respond, pro-inflammatory signals, meaning we're going to, incite inflammation so that we can try to fight off what it is that's causing an infection in our body. But sometimes, and depending on the the degree of infection, and B, how our immune system simply works individually, we can go into overdrive. So cytokine storm basically is an excessive release of inflammatory markers and cytokines, these messengers, causing extensive tissue damage. And in the case of COVID-19, we're starting to see dysfunctional coagulation, meaning the body is now throwing clots everywhere. An Italian physician coined the term microclots. Microclots basically stands for microvascular COVID-19 lung vessels obstructive thromboinflammatory syndrome. That basically means that within the vasculature of the lungs, there are a lot of thrombi, so mini clots. Again, similar to what I described earlier, but now we're just focusing on the lungs. Histopathology performed on people who have unfortunately succumbed to the disease has revealed what's called diffuse alveolar disease. And that is something that has purported to have been seen in SARS coronavirus. They also have noticed fibrosis of the lungs, meaning the areas that are fibrosed are no longer functional. And these sorts of changes, again, have been seen in SARS as well as MERS. So we all know the saying, prevention is better than cure. And right now, coronavirus has no real therapeutics, meaning we're still trying to figure out a drug that can be used to cure this disease. We're in the process, early process of developing a vaccine. Right now, we have gone through many different trials of medications to help alleviate symptoms and to help cure patients, the most recent one being dexamethasone. Considering that everything is trial and error as it stands, we are being asked to quarantine. We are being asked to wear masks and wash our hands for 20 seconds with soap and water. Use hand sanitizer if you currently do not have access to running water. Don't touch your face. Don't touch your eyes. Stay 6 feet apart. That way, if someone who is infected sneezes on you, the chances of those, droplets, those respiratory secretions containing the viral particles won't reach you, won't be inhaled. Social distancing. So do not stay amongst groups of people. Spread yourself out. Stay as far away as possible, hopefully just for the time being, to decrease the chances of transmission. Stay in small gatherings if you have to, especially with people who you hopefully know are COVID-19 free. And of course, minimize travel as much as possible. When we talk about public health implications for this current coronavirus outbreak, there is so much to consider. Many of what we have to consider, is just basically a spillover from what we discussed before with MERS and SARS, disease severity. Again, even though the general population mortality rate is 5%, that does not make this disease any less severe than what it is. So do not be fooled by numbers sometimes. Understand the context of these numbers. There's also concern for a second wave. Just as there was concern for recurrence with SARS coronavirus back in 2002-2003, we're now concerned with there being a second wave, another outbreak of COVID-19 cases. And one way to help mitigate that is help decrease the chances of that happening is to continue wearing masks, to continue our social distancing. And just to clarify, the reason why the consideration of a second wave happening later on this year is so critical has to do partly with temperature. So research has shown that coronaviruses are inactivated in a temperature that's about 27 degrees Celsius. However, coronaviruses tend to remain stable in 0 degrees Celsius. So obviously as the year goes on, we're going to start having a drop in temperature due to seasonal changes, and that is where the concern of there being a second wave comes from. Again, as I discussed morbidity versus mortality, morbidity simply means who's actually getting sick versus mortality is who's dying from this disease. And with that, you have to take into consideration, just as we did with SARS and MERS, the burden on the healthcare system. We have seen firsthand how overwhelmed the United States was over the past few months with cases of COVID-19, how overwhelmed countries like Italy was and Spain. And it makes you just ask yourself, was this preventable? Were you really prepared for an outbreak like this? Or was it that the disease just ravaged through so many people that hospitals, physicians, etc. just were not able to keep up? And as such, at least what we saw in the United States, a dismantled health infrastructure. At one point, the CDC publicly recommended that healthcare workers, because they'd run out of PPE, wear handkerchiefs or any other kind of face coverings that they could find. Garbage bags were being worn. People were creating makeshift beds. People were creating makeshift ventilator machines. That is not acceptable. Testing. We have been hearing about testing for the past few months. Testing is one of the most important things as far as disease control, because again, it gives you an idea of, real-time case numbers. And the only issue here is that everything was just so rapid, everything was so acute. So coming up with a test that is valid is very important so that you can avoid things like false negatives. You can avoid things like false positives. Before I get into that, I'm just going to talk about RT-PCR, which stands for real-time PCR, versus serology. The difference between the two is that PCR tests for antigen. And antigen is the disease-causing agent, which in this case is the virus. If you are infected with the virus and you get your nasal swab, then the PCR will be able to say, yes, you are actively infected with this virus. Serology basically tests for antibodies or your immune response to this virus. The only thing with serology is that if you test positive with this test, it doesn't necessarily mean that you actively are infected. It could mean that you have been exposed at one point and your body developed antibodies, which is now being detected. If your only option is a serology-based test, the recommendation is to get screened and then in about 2 weeks or so, get screened again, which is called paired titer test or a convalescence test, because you want to see if your antibody numbers are increasing, which would mean that you actively have the infection and your body's mounting a strong immune response. Again, going back to testing and test validity, the reason why we have to make sure that our tests are accurate is so that we can make sure that we can trust our positives and we can trust our negatives. So we have to think about specificity, which means, how well a test can detect who's negative or who does not have the disease, and sensitivity, how well a test is able to say, yes, we have a positive case. And then going further into that, we have to be able to trust the positives that we get, the positive tests, and trust the negative tests that we get. Again, globalization, no different from what we saw with SARS and MERS. With what originated in China has now become worldwide. People have been traveling, people have been moving, and what could have slowed things down is by implementing perhaps a halt in travel early on as soon as this novel coronavirus was detected and as soon as SARS and MERS had to be considerations for ruling out what could be the cause. History repeats itself, but it doesn't have to. We cannot ignore socioeconomic impact. Everyone, regardless of class, regardless of the socioeconomic status, everyone has been impacted by this disease. Businesses have been put under. People have lost their jobs. People have been furloughed. Businesses have closed, as I've said. Everyone is losing money. Everyone is impacted in one way, shape, or form by this disease. Then, of course, the mental health impact. For many months, people were told to stay indoors. And even though we are, generally speaking, undergoing different phases of reopening, we're still encouraged to stay indoors. And the time that we had spent strictly indoors had a huge impact on everyone's mental health. There was isolation. There was little interaction with loved ones and friends. And for those who are predisposed to developing depression and, other mental health complications, they could easily be impacted by social distancing or quarantining. You also have to consider people who have lost their jobs, people whose businesses had to be shut down because they could simply not be sustained in a time like this. The impact it has on not only them, but their family, their their employees, etc. It's all a trickle-down domino effect. So when we talk about social distancing, we tend to get frustrated when we see that people are not upholding what has almost been mandated, not just with social distancing, but with wearing masks. So what makes it so difficult for people to grasp, you might ask yourself? That's when we have to think about social behavior, which is described as a multidisciplinary approach to promoting health awareness and disease prevention via psychology, sociology, even anthropology, as well as understanding the determinants of health on a societal, community, and organizational level. So when we talk about health disparities, we're talking about differences in the incidence rate, prevalence rate, disability rate, mortality rate between groups with a particular disease. There are different theories as it pertains to social behavior in public health, but the two that stood out to me the most are the health belief model and the social cognitive theory. So the health belief model has several points: perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cue to action, and self-efficacy. I'm going to briefly go through each one of these, hoping that you will get an idea and understand what needs to be considered when we tell a population, tell a community, you have to make interventional changes in order for us to get over this disease obstacle that we're all facing. So the first one is perceived susceptibility, and that essentially is the belief that one has about the chances of experiencing a risk of getting COVID-19, for instance. Then there's perceived severity, which is a belief that one has about how serious COVID-19 is and all of the related consequences. And then you have perceived benefits, which is a belief that one has in the efficacy of what's being advised, as far as social distancing and wearing a mask, in order to reduce that risk of getting the disease. Then you have perceived barriers, which is a belief that one has about the tangible and psychological costs of what social distancing and wearing a mask is going to have. Cues to action basically means strategies that are suggested or implemented to activate someone's readiness to perform the advised action, which in this case again is, staying 6 feet apart and wearing a mask. And then self-efficacy. So how confident someone is in their ability to perform what has been asked or really told of them. So these principles have to be considered when we are thinking about COVID-19 through a public health lens, social behavior, trying to understand what people need and what will motivate people to engage in interventional strategies in order to help get us all over this hump. Next up is social cognitive theory. So this theory basically focuses on learning processes as a determinant of health. And I'm not going to go through every single one of them, but I'll just briefly go through some. The first one is outcome expectations, and that is the belief about outcomes of behavior. So if you're telling me that I have to wear a mask, if you're telling me that I have to stay 6 feet apart, what is the outcome? That the chances of me getting this virus and spreading it will be decreased? Well, how do I feel about that? Do I even believe that? Then outcome expectancies, perceived value of the outcomes. So how much does it mean to me? Do I really care about the outcome of me the outcome of me wearing a mask and me staying 6 feet apart? Do I really care about my own life, or do I care about, my fellow man? Then you have self-control, which is regulation of performance. So can I trust myself to do these things, or do I need to be told? Do I need to have someone breathing down my back? Do I need to be mandated? Do I need to be told by businesses, hey, you can't come in here unless you wear a mask? Or can I just do this on my own? Then you have behavioral capability, knowledge and skills to perform the behavior. Do I know enough about what's going on? Do I understand enough about what's going on about this virus, about what this means for me, my family, society on a whole, in order for me to find it worth it to stay 6 feet apart and wear a mask? So now we are going to talk about this public health disaster that we are now facing. Did we really learn our lesson from the SARS outbreak in 2002 and the MERS outbreak that is still somewhat endemic in the region that I talked about earlier? The fact that we had to make sure that we ruled out SARS and MERS back in January, back in December, means that it was considered, means that at some point someone said, what if this is SARS? What if this is MERS? Do we remember what we went through back then? And is this something that we want to go through again? What have we learned from those outbreaks? What can we implement in order to not have an experience like what we went through years ago? As a matter of fact, it wasn't even that long ago. Were we sufficiently prepared for an infectious disease outbreak? Or were we truly overwhelmed? Based on what we experienced in the United States of America, it would seem as though we weren't really prepared for an outbreak of this magnitude. We were trying to source things from other countries. We were trying to get everyone else in the population to create homemade this and homemade that, just so that we could deal with the disease. Did health disparities already exist in our healthcare system? Or did they just show up now? No, they already existed in our healthcare system, but COVID-19 allowed us to really see the health disparities that have existed all this time. There have been complaints that certain groups of people have been mistreated, have been ignored while at the ER, subsequently dying as a result, not being taken seriously. We have heard that COVID-19 cases have been exponential in certain communities. Why is that? Well, perhaps they do not have all the information that other people might have in order to make better choices as far as keeping the hands clean, as far as wearing a mask, etc. Perhaps they simply do not have access to healthcare that many others do have. Perhaps they do not have the funds. Perhaps they're simply not being heard. What about bioethics? We heard at some point earlier in the year that some doctors had to make a tough call. Some hospitals had to make a tough call as far as who gets to stay alive and who doesn't. That must have been really challenging for healthcare workers. And finally, with everything that we have experienced so far, we still have a ways to go. Will public health finally be given the esteem it's due? We need more epidemiologists, more biostatisticians, more social behaviorists, more policymakers that kind of have one foot in the realm of public health and one foot in the realm of veterinary medicine, human medicine, etc. Why is that, you might ask? Well, One Health, One Medicine. This phrase was coined many years ago, and essentially, it recognizes the link between humans, animals, and the environment, and highlights the importance of creating collaborative and cross-disciplinary approaches for dealing with emergent infectious diseases amongst veterinarians, physicians, and other healthcare professionals. We are all needed as team players in combating this infectious disease outbreak and many others that are to come. This wraps up my presentation, and here are my references. Thank you.